So thanks everyone for attending this phase webinar. My name's Ruth Hunter. I'm based in the Centre for Public Health at Queen's University Belfast, and I'm one of the co-investigators of phase. I'm just going to start with just a very brief kind of overview of what phase is about. And then I'll introduce you to Dr. Jen Badham, who's going to give us going to take the webinar today. Jen will talk for around 40 minutes, and then we'll have some time at the end for some questions and discussion. So phase is one of the UK Prevention Research Partnership, or UK PRP, networks that's been funded over the last 3 or 4 years, and it stands for Population Health Agent-Based Simulation Network. You'll see down at the bottom of the screen there's the project website and also the Twitter handle, so please feel free to go along to either of those resources and find out much more about the project than what I'll cover in the next few minutes. So what really phase is about is bringing together researchers from different disciplines, including public health and simulation experts, alongside practitioners and policymakers, really to work together to address some of the complex challenges faced by decision makers in the prevention of NCDs or various chronic conditions. So that's kind of at the heart of what the network is about. We've got some other upcoming events that I'd like to highlight. So in the webinar series is an introduction to agent-based modelling for public health that Rick Colistani in Glasgow will do on Wednesday the 2nd of November at 1 o'clock. And again, you'll find out more on Twitter and the website about that webinar. And then on the 26th of October, so next week at 1 o'clock, we've got a webinar very much showcasing some of the work of early career researchers who are working in the area of agent-based modelling. So we've got contributions from London School of Hygiene and Tropical Medicine, from Queen's, and also from Glasgow. And that's going to be chaired by Professor Steve Cummins. So that's next week's event as well. And then just to highlight, you'll see the web link at the bottom, some of the training resources that Jen and Mark McCann and Rick and others have been involved with in pulling together for phase. And this is very much a whole range of resources that have been brought together to really get people started where they're interested in finding out what agent-based modelling is, how do I get started, and start to get your hands dirty really in terms of doing some of the modelling. So I encourage you to go along and look at the webpage and some of the different resources that are available there. So that's all I have just in terms of a brief introduction to what phase is about. What I'll do now is hand over to Dr. Jen Badham from Durham University, who's going to do a webinar on justified stories, formalising what if for policy modelling. If I can encourage you to use the Q&A function for any questions that you have for Jen at the end. And if you can use the chat function just to introduce yourselves and see who's in the virtual room, that would be great. So Jen, let me hand over to you for your webinar on justified stories.
Great, thanks Ruth. Hello everyone. I just want to check that you can actually see and hear me.
Yeah, we can do both, yeah.
Excellent. Okay, so what I'm going to talk about is a particular model and how that was used in policy modelling about COVID. And the collaborators on this were Pete Barbrook-Johnson, who's now at Oxford, was at Surrey at the time, and Camilla Kyoto and Brian Castellani, who are both with me at Durham. So the outline of this is that I'm going to talk briefly about the model. I'm not going to talk a lot about it, but just to give you an idea of what sorts of things the model presents and simulates, and then how the use of it changed over the period, essentially the first year of the COVID pandemic. So Just Social is the name of the model. And it combines policy options, epidemic state progression, and epidemic transmission. That's the details I'll go into. This webinar is part of a series. Corinna Elsenreich talked about what agent-based models do last week. And one of the things that I'm sure she would have emphasized, even though I didn't actually manage to attend because I was busy, was that what an agent-based model does is you start from a theory about what your mechanisms are in the system, and then you put them into the computer and simulate to see what the implications of that are. So one of the theoretical mechanisms in just social is about epidemic state transition. So it's an extended SEIR model, so that's susceptible, exposed, infectious, recovered or removed. And what that has is that each individual agent is representing a person, and once the people start in the susceptible state, there's a separate transmission process that I will talk about. They get exposed, and then they step through the potential states. So once they're exposed, they can they become infectious at some point in time, just sort of in the community. They might recover, they might die directly from being infectious in the community without ever going to hospital, but they might get more serious and go into hospital. And again, from hospital, they can either recover, or they can die, or they can get more serious again and go to critical care. So these are the paths that the simulated people can go through within the agent-based model. And so the parameters were for this transmission, for the transition, epidemic state transition, was the probabilities and duration. So going from susceptible to exposed happens through the transmission process. Going from exposed to infectious within the community, that always happens. And so the key parameter here is about the distribution of durations, like, you know, what proportion of people does that take? 4 days, 5 days, 6 days, or whatever. From being infectious in the community, there's a probability level for whether somebody recovers or becomes more, has more serious symptoms, or dies outright. And there's also, with COVID, there's also that only some people are symptomatic. Though once they get to hospital, then they're always symptomatic. And the sources for the data for that were, you know, all the typical COVID epidemiology sources. So Imperial College had a bunch of stuff associated with their model, the critical care monitoring, the ECDC had some stuff about duration in the community, and the Office of National Statistics had information about, had surveys about prevalence and deaths and so on. Okay, so the second mechanism is about the transmission process. And within an agent-based model, in this particular one, the transmission is done spatially. So the model just had a 41 by 41 grid of patches, and infectious people can expose susceptible people or simulated people on the same patch. And each day some people move so that the epidemic actually has a chance to spread geographically. And each of the cells starts with 12 simulated people. That comes from the literature about people having 11 contacts a day. And then the transmission, the probability and the movement amounts were calibrated against a fairly standard epidemic model. So here you've got sort of a magnified part of 3 by 3 cells within the world, and the blue darts are representing susceptible people. The green circles are people who have already recovered. Orange is exposed but not yet infectious. The larger orange are infectious, and you can see, for example, that this susceptible person has become exposed in the next time step. And for example, this susceptible person wasn't actually in that area in the previous time step. So this is going from one time step to the next time step. Each time step represents a day. Okay, so that's the sort of the underlying epidemic model very briefly. And then there was some policy options. And what we had here was, well, some of them are sort of not quite policy options, they're contextual stuff as well. So how many hospital beds are available? So that if you've got to the point where a certain number of people need hospital beds, you know, they move to the infectious within hospital and there's not a hospital bed available, then that changes the probability of them dying. Then there's a whole bunch of stuff about physical social distancing. So people can reduce their activity, so that's closing public places. You can reduce transmission, so that's things like hand hygiene. You can shield people who are at higher risk, and so the model recognizes whether people are isolated or not, with the isolation having an effectiveness level. So, you know, even if they're fully isolated, there's a low risk of them still being exposed. You can reduce movement so that people don't move around as much. That was never really done in the UK, but it was, for example, done in Ireland, that people were supposed to stay within, I think, 5 kilometres of their house during lockdown. And then there's some stuff about contact tracing. So symptomatic people can choose whether to inform their contacts, and they can also choose whether to isolate. Okay, so none of these are calibrated. Okay, they are just there to allow the model users to try out different scenarios. And then later on in the model, we added some stuff about different variants. So there were the model tracked whether it was sort of variant 1 or variant 2 with different transmission rates and so on. And also, as the vaccination programs came online, then we also needed to have some people immune without ever having gone through having COVID. Okay, and so this is what the model interface looks like. The original intention was to set it up so that the policy planners could use it themselves, try out their own policy models. We abandoned that very quickly, mostly because they weren't allowed to install software onto their computers. So even if we had been able to train them, and this was written in NetLogo, it's reasonably easy to use. Even if we'd been able to train them, they wouldn't have been able to run the models. So we ended up having a to and from discussion. So that's very briefly what the model is about. What I really wanted to focus on today was the changing relationship between me as the modeler, or as the main modeler, the policy planning team in local government, which is who we built the model for, and to some extent the model itself, and how the data and model fed into that changing relationship. So the key players, and you need to know this because I'm probably going to drop their names accidentally quite a lot. There's the Local Resilience Forum, the LRF, and they have legal responsibility for coordinating emergency responses. So that's basically a partnership between the NHS trusts in the area, between the sort of the social care people, the local council, the police services, ambulance services, everybody who might be involved in thinking about COVID planning sort of came together under this framework of the Local Resilience Forum. I mostly dealt with people in the county council and the NHS, the local trusts, because they were the ones who were sort of providing the intelligence reports to the LRF senior managers. And I was doing that through sort of Durham University had a little team set up to provide support to the LRF. And that team was co-led by Camilla Caiado from mathematics and Brian Castellani from sociology. So, sort of Camilla, Brian and I were reporting through Durham County Council and NHS to the LRF. It was sort of the formal arrangement. That's not necessarily the way it worked in practice, but that's the formal arrangement. Okay, so let's go way back to March 2020. And just to remind you, here's some newspaper headlines of what it was. This was, there was, you know, there had been calls for several weeks in the newspapers saying, why aren't we in lockdown? Look at the epidemic that's happening, particularly in Italy. You know, when it was in China, it wasn't quite so close, but when it was in Italy, it was clearly coming through Europe, and Italy had gone into lockdown a couple of weeks before the UK eventually did. And then the 23rd of March, the lockdown happened. This was sort of the following day's newspaper headlines, you know, Boris Johnson saying stay at home, the Sun saying, you know, everybody must stay house arrest in, you know, not at all dramatic style, and end of freedom and so on. Okay. There was also simultaneously a call amongst researchers about, well, what as researchers and this is the European Social Simulation Association. Most of these are what was the management committee at the time, saying how can we as modelers and researchers help this sort of international crisis? What can we do that's useful? So that's what this paper is. And at the time, we sort of had public data about admissions. So this is coming from the very, very good and very useful COVID dashboard that the government produced fairly early and kept going, and is still actually going. And at the time, the only thing that they were really tracking was admissions per 100,000 people, and only at the UK level. Okay, so here we are at the lockdown. Admissions continued for a little while afterwards. That's standard in epidemics because you've still got the people who are already exposed becoming infected and needing hospital treatment for, you know, 10 days afterwards. Okay, so what did we do? The team supporting the LRF was doing several different things. So one of the things we were doing was looking at the Italian epidemic curves and basically doing statistical analysis that says our curve looks closest to this particular Italian curve, and therefore use that to say this is what's likely to happen over the next few weeks. There were several models going on, and I did a very, very basic model, agent-based model that was simply because a lot of the people working in modeling, you know, national emergency get a whole bunch of mathematicians together. Many of them had not actually worked with epidemiology models before, and just things like understanding the difference between cutting back activity versus cutting back contact. If you say that if you reduce everybody's activity by 20%, you actually reduce contacts by 20%, by 24%, because what you're doing is a contact actually has to have both people there. Okay, so, and all of this work was being done through Camilla reporting to the LRF. So over that first couple of months, I built the first version of Just Social. And there were three key elements, basically the three elements that I outlined before: the transmission process, epidemic state transition, distancing scenarios, distancing measures. And in May, what we did was we presented some example scenarios just to show what the model could do. Now, generally, I work in a very participatory modeling style where you talk to the people who are going to use it and say, what do you want, and stuff like that. You know, what sorts of questions do you want to ask? That was not possible, just because, you know, everybody was just stupidly busy, but also that's a fairly time-consuming process. So instead, what we did was we just produced some stuff, and I made up some scenarios, and they're very made up scenarios based on things like, you know, newspaper speculation about what might happen with the lockdowns and so on and so forth. But really what I was trying to do was demonstrate what the ABM do. And so here we're sort of saying the upshot here is holding the reproduction ratio, which I'm sure you all know what that is now, but it's effectively how many people each person is able to directly infect. Holding that at 1 doesn't actually kill the epidemic. It just delays it until you pull back from the distancing measures, let everybody go again, and then it just takes off. And then there was various things about, you know, whether isolation was going to be enough and so on and so forth. And the idea was just to sort of say, well, probably not any one scenario is one measure is going to be enough, but the sorts of things that that tend to deliver good control is where you have a combination of measures. But really what we were doing was just demonstrating the model. We also wanted to demonstrate uncertainty. So we were producing plots like this that sort of have each of the individual model runs with the average run in the dark line to remind the policymakers that this is a model, this is an estimate, and you know there's a lot of variation involved in it. So we were emphasizing uncertainty at this point. So after we had demonstrated it, in June 2020, sort of I'm at Durham University, and you may remember Dominic Cummings, while infectious, drove across the country to stay at his family's property, and then driving back stopped off at Barnard Castle, as he stated it, to test his eyesight. His family's property is in Durham, where I work, and so you know this was a national scandal, but there was also local implications, very much about behaviour, and you know if he's not going to follow the rules, then why should we, type thing. So but this is where we were in June, was that this was sort of the big scandal. We still had the same sort of data available, and there was a continued decline in admissions. But what we started getting at this point was, after the demonstration, the various LRF and intelligence team members were starting to ask us about scenarios. So we created some scenarios. So what we were trying to do was sort of say, what do we think the likely prevalence at end of lockdown would be, or the probability that the lockdown could eliminate COVID-19, but also things like what has been achieved by lockdown. Like what at the time there was lots of things. Well, we've been in, you know, sitting in our houses for 2 months. It's still, the epidemic's still going. What have we actually achieved? Is it going to stop or not? But we also started getting specific questions like what can be achieved with track and trace. And at this point, we also started talking to them about the assumptions. So when we started talking about what can be achieved with track and trace, we were having conversations like, well, what proportion of people do we actually think will isolate if they're told to by the track and trace team? And, you know, there was the optimistic, well, surely everybody would, because, you know, they've been told to, compared to the, well, you know, their job relies on them being out delivering parcels or driving taxis or whatever, and they're on gig contracts, and they can't possibly afford to just sit home and isolate. So we were starting to have those sorts of discussions. We also at this point found out that the hospital, well, we knew it before that, but we hadn't realized I personally hadn't realized how bad the estimates were. That they were getting centrally estimated numbers, which didn't reflect the fact that, you know, Durham epidemic really took off a couple of weeks after London. So the central government was generating these reports and estimates that were an order of magnitude out. And so, you know, there was one weekend that they were told, oh, you know, you're going to get this huge number of admissions. They rostered on way more nursing staff than they actually needed, and they were worried about burning out their staff with working against those numbers. So this was one particular scenario that was presented. I'm not going to explain what it is, but basically it was saying that, you know, if the central government is responding to the admission numbers in London, what are the implications for the admission numbers in Northeast England? And basically, because the epidemic was had hit Northeast England later, there was less herd immunity, and so that meant the consequence was that we would get a smaller first wave and a larger second wave. Okay, so moving on a few more months, and at this point, we were starting to provide regular reports. So, so here there was starting to be pressure on the government again for a lockdown for the second wave, and there was new data in the dashboard. It was still admissions focused, but we could actually look in regions. So you can see here the orange line is Northeast and Yorkshire. And the green line is UK generally, and you can see that, you know, we were actually getting this bigger second wave. So from mid-November, they actually added occupied beds as well as admissions. So what we did was we we created a scenario that sort of tracked the admissions, that replicated the admissions that had happened in Northeast England, to try and say, this is what we think the epidemic looks like within the parameters of our model we matched to admissions, and then sort of extrapolated with different assumptions of post-easing activity. So this was going to be the second lockdown. What would happen at the end of that second lockdown, assuming different levels of how quickly people started resuming their normal activities. And we were providing fortnightly reports and updating our scenario against the actuals. So we were giving projections of beds and admissions, and then updating every couple of weeks. And gradually over this period, this model got embedded in the dashboard that the planners were using for, you know, staffing and whatever else. And we had equal status in this dashboard with the official Public Health England projections. And we were also starting to talk to the LRF leadership rather than the intelligence team. So we'd sort of got more and more deeply embedded in the policy planning process. And this is sort of a typical thing from one of these reports. The red dots are the actuals. This is admissions. We also later on were able to add at the Durham county level, not just the Northeast and Yorkshire level, but this is just Northeast and Yorkshire. Sorry, no, this is UK dots that we just prorated down to Northeast and Yorkshire. And so this is, don't be impressed by how closely this fits, by the way. This is the hand-tooled scenario to sort of say, this is what we think, this is how we can reproduce the epidemic that happened, and then here are the projections out here. So this report was produced at about this point to say, as the restrictions are eased in December 2020, January 2021, where do we think it might go? And you can see that, you know, it wasn't, only the very optimistic scenario had the epidemic actually dying out. So at this point, these assumptions were actually developed with the council and NHS contacts. And so what we were doing was sort of saying, okay, so the optimistic scenario kind of continues the activity levels that people were observing during lockdown to get this same to get this matched thing. What about, well, maybe we think they'll do the same activity levels that happened coming out of summer. So going back to the activity levels that generated this part of the curve in September 2020, what do we do? What does it look like if we put them in as inputs for the future? And that gets this sort of line. And then this fast takeoff line is if people just go back to normal type thing. And on the right here is hospital bed projections, bed need projections, because they were actually much more concerned about bed use than they were about how many admissions. Then we got some much better data. We went down to the county level rather than just the region level, and that's what the blue dots are. And you can see that there's way more variability in those. The admissions were actually not that great, but the bed occupancy was still pretty good. So we actually didn't really update the model for that. So then in January 2021, new conditions. Like this is when we started having the sort of the lockdown to end all lockdowns, vaccination coming. We started getting bed data and so on. And this was a very much, by this stage, the model was sort of we were fully engaged in having this discussion, that the model was embedded in the planning processes. So all of the activity levels were actually selected by the council and the trust, you know, for the different scenarios. They chose them. I worked out how to introduce new variants, but talk to them about and vaccination, but talk to them at quite a technical level about how I was going to put that into the model, and we discussed that and they agreed to it. I mean, it was my idea, but they were deeply involved in the technical details at this stage. The projections were in the planning dashboard, as I said, and you know, we were briefing the actual senior LRF at this point. We also did some stuff about looking at the duration of hospital stay for the local hospitals as compared to the national averages. That didn't really go anywhere, so I won't talk about that in any detail. And so this was sort of, you know, the sorts of scenarios that we had at this for the January reports, very much the same as the previous reports. They specifically asked for long-term projections that were heavily caveated, but they were just sort of trying to see whether the short-term decline was related to a long-term decline or not. And you can see we're still emphasizing the variability here. And the projections are starting to get a bit rougher and rougher. Okay, so why model at all? It's kind of easy to think that these projections are the important part of this exercise. So we were comparing scenarios, we were assessing the adequacy of the scenarios, we were directly supporting decision. And you know, that's true, that was important. They felt more comfortable with the projections as part of their intelligence. For me, as a modeler, this is incredibly uncomfortable. And that's because agent-based models are not for prediction. The scenario output that I was generating was being added to the hospital planning tools, within an hour or two of me giving it to them. Reflecting on it later, though, it was actually less like prediction and more like intelligence or surveillance. So their dashboard had lots of models in it. And so it compiled information so that the planners could actually think through, all of the bits of information they had, and it kept track of anything that was useful. It didn't say that these projections are what's going to happen. They were just tracking every bit of useful information they could. And in that context, I was much more comfortable about these scenario outputs being included in their dashboard, that they weren't making decisions based on my model output. What they were doing was using my model output as part of their awareness of what could happen, and along with various other pieces of information. There was also a lot of indirect decision support going on. So they were gaining experience in complex systems thinking. Some of the stuff that happens with complex systems is very counterintuitive. Even something as basic as, well, you do the lockdown, why are the admissions still going up? Does that mean the lockdown's failed? That sort of delay is something that is obvious once it's been explained to you, but you look at the data and think nothing's happened. So the delay is not something that comes naturally to people's thinking. So by working with the model scenarios, their intuition was being trained so that they could make decisions, or better decisions with sort of only limited limited information, and recognize uncertainty, because the model was sort of giving them a fake world, if you like, that had those sorts of things in it that they were able to learn in. There was also this stuff about explicit assumptions, things like articulating, well, what percentage of people do we think are likely to comply with isolation requests? And that was also part of making those sorts of assumptions explicit is also part of indirectly supporting decision making. So, as a modeler, the purpose of this just social model is kind of descriptive. So it's not really designed to explain or to predict, but to represent the systems and the relationships and dynamics of the situation. But ultimately, what it is, it's a tool for thinking. So the model provides a convenient access to organized knowledge. So you start with, this is how we think the world works, put that in a model, and then the model tells you the implications of that. It doesn't tell you anything you didn't put into the model in the first place. It tells you the implications of your understanding of the world, and says, well, what would happen, or what could happen really, if our assumptions about how the world works is correct, and this particular situation changed. I ended up calling that justified stories. Now, I've been a modeler for more than 20 years. And part of that, when I talk about modeling, I've always talked about what it's good for is what if. What if we did, what would happen if we made this change to the system? And doing this project made me very much think about, what do I mean by what if? And I ended up switching to this other terminology of justified stories, because what I wanted to emphasize here is two aspects. The first is the story aspect. So a story is a story because it's internally consistent, it's coherent in some way. If you read a book and a bunch of characters just appear out of nowhere, do something random, disappear, you never see them again, or something happens that is completely inconsistent with the rest of the story, it's not a good book. Okay, a story is a story because there's a sequence of events that happen from some sort of internal logic. Now, it can be a logic that you're not familiar with. Science fiction, for example, does that well, but the logic of the story is internally consistent. And then the other aspect of this is that those stories are plausible. They're consistent with what we know about the world as it exists. So, you know, the model was calibrated against various types of data. So if the model was producing numbers that were very different from what the evidence tells us about the world, then the stories that came out of the model are not really all that plausible. So the plausibility of these stories is justified by the consistency, the external consistency with the data. And there were multiple sources of data of structure in the model. You know, there was data, there was theory, there was expert opinion. All of that is built into the model. So this idea of justified stories and what if is quite different from prediction as such. You know, in terms of, you know, inflation's going to be 10% next year or whatever the current prediction is. We're producing lots of this is the way it could go. That's what justified stories is. These are plausible futures, rather than trying to focus on one particular future and say, this is the one that's going to happen. And to do this, both theory and data contribute. So the theory provides the causal mechanisms to create the stories and allows those stories to deal with change. Because there's theory embedded in the model, we can say, well, what happens if, you know, half of the people decide to stay at home? Statistics can't tell you that, because statistics can only summarize and extrapolate from the unchanged world. The data set that describes the world now, you extrapolate that data, all you're getting is, well, the world as it happens now, as it is described now. It can't deal with things like, well, what if the world changes? And the big advantage of agent-based models, and you know, there's other modeling techniques in this sort of domain, is that they combine theory and data in a very natural way, and you want them to be balanced in depth. And by that I mean that you don't want, you know, a very, very specific value for a parameter if that parameter is kind of only vaguely used in the model, or the other way around. You don't want to have stacks and stacks of process in your model, but only have really bad data for a couple of them, because the model then is inconsistent, that it sort of looks more credible than it is on one side, and you know, so you want to balance the depth of the data with the depth of the theory. Final couple of slides. What I want you to take away at the end of this really is that the model insights are not always the obvious ones. Models are a tool for thinking. They summarize knowledge, extrapolate that knowledge. It's not always about, well, the model projection said, you know, tomorrow we're going to have this many admissions, and that's the important thing. Sometimes it's just about helping you to clarify what you think. And justified stories is sort of a more formal version of what if. Modeling scenarios is more than just speculation. It's extrapolating from your understanding of the theory as best informed by the data. And both of those elements are relevant. So database prediction is insufficient for policy, because if you've got a data set, you can only extrapolate the world that the data that generated that data set. And going down sort of big data doesn't really resolve this contradiction. It doesn't matter how much data you have if it's data about a different world than the one that you're going to be actually working in, because you've made a policy change. So formulating that sort of those sorts of ideas properly is this is a paper that's coming out that that Corinna and I wrote a few months ago, that is looking very much about the way that theory and data interact in justified stories. The other thing to take away is that policymakers did actually value the insights, even though they knew that the model wasn't really that good in some sense. They got very deeply engaged. They were talking about fairly technical matters, and the only reason that they would have done that in what was an incredibly busy time for them was because they were getting something out of it. They were finding this thinking assistance helpful in them making their decisions. So that's the end of my my slides.
Great. Thank you for that, Jen. Brilliant presentation, and clearly a huge amount of work in a pretty short period of time.
I was busy, yes.
Yeah, I can tell. Lots of claps going up the screen. We've got a few minutes for questions, and if anyone else wants to ask some questions, say please pop them in the Q&A or in the chat, and we'll pick them up. So I've got a question here, Jen, which is, have you considered effects of testing such as PCR and LFT and vaccination in your simulation?
Not in that one, because that model started before that. I do actually have a separate model. So Durham University was one of the trial sites for changes to, when LFTs first came out, for changes to rules about, how quickly people could go back, how many days negative do they need to show and stuff like that. I actually did build a model for that, and we never used it. But no, it didn't get into that model. And in fact, that particular model, the policymakers wanted to continue using, even just a few months ago. But the model, the world as represented in the model, was the world that existed back in March 2020, and the changes I'd made for variants and vaccinations were okay as short-term hacks, but the world now is so different that I'd want to start the model again. And honestly, statistical tests, statistical predictions and so on are kind of okay now, because it's a bit more stable with the policy sets.
Yeah, I'm interested in how. And you give some reflections in how you normally do ABM work versus that context. And you said that generally you work in quite a participatory kind of model, which obviously wasn't possible in this context, or certainly not in the depth that you would normally do. So I'm just wondering what impact you think that had in terms of the research and the model produced.
I think that there are probably some things that would have gone into the model if I had done a proper participatory process. Things like I hadn't really envisaged, it doesn't have any age structure in it. It has sort of a high risk and low risk population, but it doesn't have an age structure. And that made it really hard to deal with things like vaccination programs, which are obviously age-based when they came along. And that sort of thing would have come out in a participatory modelling, because they would have thought more about what their scenarios were likely to look like. Partly that was a time thing, partly was because we didn't have any data, so why bother putting in an age structure and so on and so forth. But we were very, very lucky. I had experience with epidemic modelling. One of the key people in the public health group, intelligence group within the council, is trained in operations research. So she was comfortable with models. She'd never seen ABMs before, but I didn't have to grapple with that whole, no, you can't go and believe these numbers thing that I often have to grapple with as part of the participatory modelling thing. So getting people used to what models can and can't do was a much shorter process than would have been the case if there wasn't mathematical modelers in the team we were advising. So we were lucky. But yes, I would have liked a better process.
Yeah. Okay, we've got a question here from Rich. He said, brilliant presentation, Jen. He's surprised how easily the users embraced uncertainty. And do you think the ability of ABMs to show that helped, or was it the emergency nature of the situation, or the fact they were seeing everyone on the TV, etc., talk about uncertainty?
I don't know, actually. It might have been because of the sort of the mathematical competence of the policy team we were advising as well. I will have to ask them. That's a really interesting question. One of the papers that I have kind of started thinking about, but haven't really got more than about 100 words of, is trying to document this process, this policy modeler interaction as a case study. And that uncertainty thing, I think part of it was because some of the numbers that they were getting from, central PHE were so wrong that the credibility was low anyway. So they were quite comfortable with knowing that things were approximations, and they were never using, there's going to be 100 people next time. They were normally when you sort of produce things with variability in the plot, somebody says, can we replot that and take out the variability? Just give them the line or something like that. We didn't get any pushback on that at all. So that's an interesting question, Rick. I will have to ask them.
Okay, great. I have another question here from Jonathan Stokes. Really interesting presentation. He's interested in how you've used the real world data to calibrate the models, and do you use a holdout sample to test for possible model overfitting like machine learning approach would use, for instance?
No. Partly, there's a couple of reasons for that. First of all, machine learning doesn't have theory in it. Okay, so this is kind of this difference between statistical modeling and mathematical modeling. We start from the theory. We say we are representing this set of mechanisms, and then the data brings us into plausible ranges. When you're starting with when you're doing machine learning, you're kind of saying, here's the data set, how do we summarize this best? And we don't actually care how that prediction is generated. If it's a better prediction, then let it be as black boxy as you like. And so overfitting is much more of an issue there. Overfitting is not an issue when you're saying this is the things that we're fitting. This is the process that we have embedded in our model. What are the numbers that best explain, that best bring it in line?
Okay, great. We've got time probably for a couple more. So I've got one here from Maria, who's particularly interested in the calibration and validation side of the work. So can you give a bit more detail just in terms of the methods used and the extent to which you found these methods efficient and effective, especially given the need to base almost real-time policy decisions upon your model?
Yeah, so it was being constantly updated. So the first version was just based on, things like right at the beginning, R0 of 3, here's what we think the transmission parameters look like based on the initial outbreak in China. And, those numbers are reported in the Imperial College set of reports. And I just used them for the first version. And the parameters in mind that were different, that sort of had no real world equivalent, like how much do people move. What I did was I went to the Penn State model, which is a population level model, plugged in, the parameters we knew, R0 equals 3 and so on and so forth, generated a curve of what an epidemic looks like, and then fiddled with my my movement parameters until I got a curve that looks the same. Very highly technical. Then 6 months later, when it was a bit quieter, I updated all of the parameters, and so some of those were updated because the source information was updated. Some of them were updated because one of the things that I realized was that the model had a much higher probability of the epidemic dying dying out than was real. Like the lockdown should have knocked out the epidemic, and it didn't. So what that meant was that I needed to have more transmissions, but a smaller proportion of them going to hospital, so that the epidemic continued, but I was still being able to match to the pattern of hospital admissions. So I made those adjustments. And then, you know, that was sort of the really big ones. And then after that, it was just about adjusting activity levels to make the back fit look vaguely correct.
Okay, brilliant. One last one then from Alice. So Alice is wondering, have you any tips for how to start the modelling discussions when the policy team doesn't involve people with prior modelling experience, and how you need to set out the types of things a model can and can't do?
Yeah, well, I don't often have that in the initial discussion. My initial discussion is often about how does the real world system work. So I will have in the room, for this sort of case, I would have in the room something, you know, some people who knew about epidemic modeling, some people who actually knew about human behavior, some consumer representatives who, you know, might talk about the things, well, you know, nobody would actually really do that because of these facts of life, like the gig economy and stuff like that, and actually step through. So say, okay, so how do we think people get infected? And, you know, the room would say something along the lines of, they spend a bit of time too close to somebody who's already infectious. And then what happens next? And I actually step through their understanding of the mechanisms that happen in the world. And then I will build, you know, some influence diagrams, some process maps and stuff like that. And then I'll build a sort of a rough and ready model from that, and then go back to them and say, okay, this is what that sort of generates. Does this kind of look realistic? Like, is that does an epidemic really look like that? And that might come back and say, no, it doesn't move across the country that fast, or whatever. And so that then becomes an iterative process. But I start with, what are the mechanisms in the real world, with as many people with different perspectives as I can talk into being there.
Okay, great. Thank you, Jen. Just looking at the time, and we're bang on 2 o'clock. So I just wanted to say thanks again for a great webinar, and just showcasing a really brilliant and intensive piece of work. I'm looking forward to seeing your other uses of justified stories in your other publications coming out. The webinar and the recording and slides will all be available on the FAIS website in the next few days. You can find out more then, and feel free to get in touch with Jen if there's any more questions or some follow-up. So thanks everybody, thanks for attending, and thanks again to Jen.
Thank you everybody for coming along.